Hello, everyone. I'm Nurse Linda from the Christopher and Dana Reeve Paralysis Foundation, and welcome today to Ask Nurse Linda Questions. We get to talk about a whole bunch of things, which is really kind of nice to do. I am a lightly pigmented female with clear glasses on, and I have brown hair. Today I have on a blue sweater jacket because we're having a lot of storms here where I am, and so it's really kind of cool, which is lovely that the heat dome is now gone. I wanted to tell you about a couple of things that are coming up tomorrow. There's going to be a webinar you can see in the chat box how you can sign up for this. It's from the company Onward Medical, which is doing those nerve stimulators, the ARC-EX nerve stimulators. They've got a new study that's coming up to help people control their blood pressure. So if you have autonomic dysreflexia, low blood pressure, all these kind of problems that come up, we'll have to see what they have to say about it, but that's at 12 p.m. Eastern tomorrow. So be sure and sign up if you want to attend that so you can get the link to go to that. And then also I wanted to announce that the professional webinar in November is we're going to highlight John Chang, PhD, who you might know because he's worked with the Reeve Foundation for quite some time. And we're going to talk about mental well-being and all kinds of things. He's just delightful. We're work buddies, so we get along real well. So it's going to be a lot of fun. So we have tons of questions today, which is always wonderful. Yes, Leon, I'm excited about that webinar tomorrow. Anything with that, anything with the external body stimulation, I think is just fabulous. So anyway, one of the several of the questions that we have pertain to pressure injury, and this is such a huge problem. Most people don't really think too much about pressure injury until they have one. And then it really can be quite difficult because they can be challenging to heal and there's just all kinds of complications that come with that. So let's talk first for a moment about not getting a pressure injury because the goal is not to have one. But if you get one, just remember it's probably not your fault. Different things happen for different reasons. It's nothing to be like, oh, I've done something wrong and now this has happened. It happens for a variety of reasons for people. Sometimes your autonomic nervous system just isn't working as much as it should be working. That's those things that happen automatically. And so people tend to sometimes get more urinary tract infections or more skin breakdown. Other people don't seem to do anything about their issues and they don't have a problem. And so it all comes back down to that autonomic nervous system. But be sure you get proper seating and bed overlays so that you have protection. Now, people always ask me, what is the best cushion to get? I want the best one. And I hate the answer, but the answer is there is no best one. The best one is the one that's right for you. You need to talk to your healthcare professional. You need to chat with your therapist. You might try out some different cushions and see, but they will look at your body makeup, your content, how much you can move, if you can do your wheelchair push-ups and relieve pressure. You can do push-ups, you can lean from side to side. If you have a power chair, you can tilt back and forth. And you have to do those consistently, and you have to start early with those. So sometimes people don't have a pressure injury for years and years and years, and they don't understand why. And the reason is because our bodies age, our muscles become thinner. And if you haven't started this practice, you maybe have done some damage early on underneath the skin where you can't see. So you need to do your pressure releases, you need to turn, you need to have all those things happen to your body. So you need to get the equipment that's right. Now, somebody had asked the question about, is it okay to get a memory foam mattress for a quadriplegic? Now, if you're talking about a memory foam mattress that you go to the mattress store and buy, I will give you a clear answer on this. No, it is not. Because what happens is the memory foam, a lot of it, not all of them, and I don't know all the different brands and how they're constructed, but generally speaking, no, because a lot of the foam that you get, like some people will say, well, why should I pay all this money for a prescription seating cushion when I can go to the craft store or I can sit on a pillow? Well, a lot of foam that's made that you get at the craft store or the memory foam or a pillow, it collapses and it makes more pressure under your body because it doesn't disperse the pressure out around the pressure areas where the bony prominences are sticking out. They stick on the inside of your skin. So if you're this is the inside of your skin is here, and this bony prominences stick right in there. And so that's what we're really trying to protect, because that's mostly where the pressure injuries come. Now you can get a pressure injury anywhere. You can get one on the side of your leg if your leg bag gets too tight and is rubbing up against there. So, you can get one anywhere, but you really have to watch those bony prominences, and you have to do your turns and you have to do your push-ups. That's the only way you're going to avoid them. Now, I know I have a reader in here who's having just a disaster of a time. They've had this pressure injury for 4 years and they're looking for a new treatment. So there's all kinds of treatments. At that point in time, when you've had an injury for 4 years, it becomes a chronic injury and they are harder to heal. But if you see that change in your pigment on your skin, if you're a lightly pigmented person, you'll see like a purplish spot. It's usually over the bony prominence. And we have this wonderful skincare booklet that has pictures of where all the bony prominences are, every single one of them. And so that's very helpful. If you're a darkly pigmented person and you have a lot of melanin in your skin, so your skin is darker. Sometimes that change in pigment will look kind of dark purpley, or it might even turn kind of like white, and some people will call it ashy. But if you get a pink or purple change, especially over bony prominence, but anywhere on your body, you want to avoid any kind of pressure being on that area. So that means the minute you see that first sign of a pressure injury, and that's a stage 1 injury. So the minute you see that, you have to stay off of it. And people will be like, oh, no, no, I've got to get up and go to work. Or, oh, I've just got up in my wheelchair so I could go brush my teeth. Well, remember, if you have stayed off that area, say all night, and then you get up and you get in your wheelchair to go brush your teeth, you are applying pressure to that stage 1 pressure injury, and you're negating the whole time you stayed off of it. So you're starting over again. So you have to stay off these things. And people are like, well, I have to go to work. Well, if you have to take a couple of weeks off work because you have a stage 1 or stage 2 pressure injury, or even a stage 3 or stage 4, if you have to stay off that for a couple of weeks to heal it up, it's better to be off work or out of your regular life, doing things, and be off of that area completely to heal. Because when you get big injuries like these stage 4, they're much more challenging to heal. And some people think, well, I'm sitting on my cushion or I lay on my pressure dispersing bed overlay, and they help reduce your risk. But there is not a device in the world that has yet to be that has yet to be invented that can make you 100% immune to pressure injury. So there's a lot of factors: your diet, how well hydrated you are, your body habitus. So if you have a lot of fat deposits in your body, that puts you at a higher risk. Everybody has some fat, but sometimes people will say, oh, I've got a lot of cushion, I've got fat in there. Fat collapses like a pillow, and so it adds more pressure. But on the other hand, if you're a very, very thin person, you have less protection in your muscles. That the muscles are really the padding that we use to protect our bony prominences that are inside our body. So either one of those, can work either way. If you're incontinent a lot, if it's stool or urine, if you
Oops, looks like Linda might have frozen. We'll just give her a moment to reconnect. While we wait for Linda to reconnect, please make sure that you are taking a look at the webinar chat box. We have some great resources that are being presented there by our information specialist. Oh, it looks like Linda is back. Linda, can you hear us?
I can hear you. I hope
Okay,
you can hear me.
wonderful. Yes.
Okay,
Great.
I'm down to trying here on another device. So
No
anyway, I apologize for that. We are having some weather difficulties here. But when you get to that stage 4 kind of pressure injury, you want to be sure and talk to a wound care specialist. And so talk to your healthcare provider and see if you can get a specialist, because there will need to be different for each stage. There are different treatments and there are a variety of treatments. So you need to find somebody who really knows what they're doing and see if they can get that wound cleaned up by secondary intention. In other words, doing dressings and, putting medication on it or whatever. There's also a device called a wound vac, which when you get into these real serious wounds, these are a very good thing to be trying, because you put it's like a vacuum and it goes over the wound, and a plastic sheet goes over the top, and it draws out the secretions and any infection or any decaying material. It draws out, and they only have to be changed like every couple of days. So that's kind of nice. Now, a lot of people don't like the sound of the vacuum because it's kind of loud, but you have to stay off of these to heal them up. And sometimes people will say, well, I've got my dressing on and I'm on my cushion. Apply that bone pressure and you're sitting.
Linda, can you hear us? Okay, I know Linda mentioned that she was having some storms in her area. It seems like she may have some weather affecting her. So sorry about this. We're just going to give her a minute to reconnect. Thank you all for your patience.
Okay, I've switched on to another server now, so we'll see if this works out. Can you hear me?
Yes, we can hear you.
Okay, thank you. Okay, so let's hope. Keep your fingers crossed. Okay, so hyperbaric oxygen chambers are sometimes used where they put extra oxygen in on the area, and then the last thing to do is to do a flap and a graft surgery. So, we always want to be cautious about having surgeries, but they'll take and remove the area where the sore is, and then they pull some of the muscle over on top of where the bony prominence is, and then they'll rotate the skin around to cover up all of that area. And then you have to stay off. If you have surgery, you usually have to stay off the area for like 9 months, because if you sit on it, it's just going to tear open again, and you can't keep doing surgery over and over again. So these are all issues. So, if you have to stay in bed for 2 weeks when the wound is just starting, like I said, it's a lot better than if you end up in the surgery position where you're in bed for 9 months is usually the minimum. And then you have to build up your skin tolerance. And then you have a scar, and scar tissue is not elastic like your skin. So once you have a pressure injury, you always have a scar. Even if it doesn't break open, there's a scar tissue on the inside of your body. So you'll be more prone to them. So avoiding them at best is absolutely the best thing you can do. But that's where we're kind of in that situation when we're looking at these really horrific wounds, which can really change your life a lot. Is there any I'm not sure what this question, diagram available for organizing assessment and care for new paraplegics. We do have this little booklet called The First 90 Days, and it's very nice. It's information that you can get, and it kind of outlines, when you first get home. Now, a lot of times people think transition from the hospital, we've taught you everything you need to know. Working in the hospital, I know, we think we've well prepared you, but when you get home, it's a whole different ball game. In the hospital, maybe you had your bowel program at 5 a.m. in the morning. Maybe you don't want to do it at that time when you get home. So you need to look at these different factors, but this helps you kind of go day by day and just kind of live in the moment. So the first day is so overwhelming and it's so difficult. Just get through the first day with what you need to do. The supplies look different. The equipment that you have at home is different. How you arrange your house that makes it convenient for you. You're going to be discovering things all along the way. So if you get this book called The First 90 Days, it's not a book, it's a little sheet that gives you information, but it's very helpful, kind of gets you through that first 90 days. And, the first day you get home, the first week you're home, maybe you're home for a month. You don't have to have it all figured out. You have to do your bowel program. You have to do your skin protection. You have to do your bladder program. You have to take your medicine. You have to do your stretching exercises, all those things you have to do, but you will find a rhythm and you will get into your own uh, ability to be able to have more control over your life. So, you've been home for 2 weeks and you're like, boy, I'm doing nothing but self-care all day long. And it feels like that way, but you will get your rhythm and that will all straighten out in time. Is there a tool? There's somebody who's concerned about being able to get equipment and they're having a struggle with, it seems like things are getting worse with being able to get things and being able to do things. And I always hate to comment on people's mental well-being because it's a very personal thing and it's very upsetting to people, but it sounds like maybe there's some depression going on here. So you might want to talk to somebody. It doesn't mean that you have anything wrong with you. It's just that sometimes life is overwhelming. And so you might want to chat with somebody about all these different things you're doing because the list of things that this person's dealing with would overpower anybody. So think about talking to somebody, but know that things are kind of loosening up in the healthcare world. So as people are getting older, people are able to get more like transfer equipment than they used to be able to get. And there are things that we're going to be talking about shortly, like these new external nerve stimulators that are just coming to market now. I mean, this is becoming a real thing. And so there's so much optimism for the future of people with paralysis right now. There's so many wonderful things going on. I mean, I have worked my whole career and I thought, I hope to see some progress by the end of my career. And now I get to live it. So I've gotten to live through all of this and the struggle and the thought of, oh, this is coming out. And well, that didn't work out so well. And so now we have to move on to different things. But, we started out, we started out telling people, you're paralyzed, that's it. Live your life, do the best you can. That is not what we say anymore because people are getting return of function. And it doesn't matter if you have a brain injury or spinal cord injury, people are starting to get return of function. We're starting to know more about things to do with these stimulators and things that are available. There's an implant if you're on the ventilator and you want to try to get off that, that's available now. You can go to your doctor and ask for a diaphragmatic nerve stimulator and you can get one. And they're from the Cleveland FES clinic, Functional Electrical Stimulation Clinic. And there's a Dr. Anders there who has developed this diaphragmatic nerve stimulator. And so he will work with your doctor or with your surgeon. It's any thoracic surgeon can put these in. It's a surgery that they do for other things. So it's not like it's a new surgery, but the device is new. And so some people are getting completely off the ventilator, which helps expand your life expectancy. Some people are off the ventilator in the daytime, but maybe they use it at night. And so these are all really good, these are all big pluses that are coming out. This Onward Medical that has this ARC EX is a stimulator that is, I call it a tape because this is what it looks like. It's a tape. It has electrodes in it, and it runs down the outside of your spine. You can either put it up in the neck area or you can put it lower in the body area. And that has FDA approval now. Now the rollout is kind of slow, because everybody wants one now, but the rollout is slow, and it has to be because there's a lot of doctors that have to be educated on how to use this, how to prescribe it. People have to be evaluated. You don't want to get one if it's not going to work for you. So, there's a lot that goes into it. Therapists need to be educated about it, and then the patients need to be educated how to use this. So it's a huge process, but it's available. It's FDA approved now, and there are like 9 other companies that are working on something similar. So this is stuff that's coming out, and people that are getting this external tape on their back, this ARC-EX, they're having improvements in hand functioning. They're having improvements in breathing. People that have it lower are getting better bowel and bladder control and some muscle movement in their legs. Now, I want to say, does this make you better? No, it does not. But it's a huge step ahead, and if it can improve your functioning so that you can feed yourself, or you can use the computer, or I have a very good friend, and I know the people at the foundation will be laughing when they hear this, and he says, I don't have to drink a beer with a straw anymore. And I thought, there are those things in life that are so wonderful. So it's really going quite well.
Linda might be frozen again. We will give her just a moment to get back with us, probably switch devices, and then we will proceed. Thank you again so much. We're so happy that you're here, and Linda will be right back. Hi, Linda.
Okay, how long was I off? Because I've been talking
Not
and I
too
could
long, not too long.
okay, I could see myself moving, so I thought, and I thought, have I been talking to myself? Okay. So anyway, the ARC EX, and we're going to have this new program tomorrow about an extension of that program with the blood pressure study. So this is really a thing that's really going. Here's a person that's having some pain control issues, and we have lots of people with pain control issues. When you have a spinal cord injury or a head injury or stroke, you can have something called neurogenic pain, and that is different from the muscular pain, or if you had a surgery and the surgical pain. So we have a pain booklet and explains all the different kinds of pain. So if you're being treated for pain, for neuropathic pain, nerve pain, and you're taking opioids, that is not going to treat your pain. If you're taking Tylenol, that is not going to treat nerve pain. So you have to take medications that treat the nerve pain. Now, for anybody, if you've had a spinal cord injury or not, or a head injury or not, but if you've had a toothache and you've had a nerve that gets, hysterical in your tooth, if you've ever had that pain, that's what neuropathic pain is. It hurts like a devil. And so, you can go to the dentist and get your tooth fixed pretty easily, but you can't fix your brain or spinal cord that easily. So it's these miscommunication of messages that is giving you the pain. So what you need to do is you need to take medication for the pain problem. And that is either, there's two medications specifically designed for this pain. They're gabapentin and Neurontin. And I know we had somebody who's written in about their husband, and they've tried the Lyrica and they've tried different things. Some people take Lyrica is pregabalin is the name of it, the medical name for it. And some people will take the pregabalin or the Lyrica, and it doesn't do anything for them, but they'll switch over to the Neurontin and it works. And some people take Neurontin and it doesn't do anything for them, and they'll switch over to the Lyrica and then that works. So it's kind of a highly educated guess how you treat all these different pains. And now there's a very interesting thing also that goes with neuropathic pain, because those are the big guns. You get those two medications, those are the big guns. But here's an interesting little fun fact. People who have depression or epilepsy, they have seizures, and they're already on these medications, they never have neuropathic pain, because the medicine that you take for epilepsy, the medicine that you take for depression has a side effect of stopping neuropathic pain. So sometimes they will give you some medicine that's a small little dose. So like if you have depression, you might take 300 milligrams of a drug, and there's lots of different choices. But if you take like 5 milligrams of that same drug, it won't treat depression, because you don't need treatment for that, but it will help your neuropathic pain. Same thing with seizure medication. You take little tiny doses and it helps with neuropathic pain. Now, there are other things. There are nerve stimulators that you can use that will help break the pain. There are different things. Some people get a lot of luck with biofeedback. This is all outlined in the pain book. And so there's different levels. Some people will do non-medical treatments, and they'll use that, but they'll also take some medication, but maybe they'll use a nurse. So people will use different combinations of these treatments to try to find it. And everybody's different. Everybody's pain is different. You're not going to find anybody whose pain is exactly like yours. So you go to somebody who knows how to treat neuropathic pain. It could be a spinal cord injury specialist. It could be a neurologist. It could be a pain specialist. And you have to work to find the right combination, or maybe it's just a single thing that you can do. So you have to work to find the right thing that's good for you. And it can take some time. So you have to be very patient. And when you're having pain, patience is not something that we all have. When we're having pain, we want it taken care of right now. So be sure and get that pain booklet. And then if you haven't been to a spinal cord specialist or a neurologist or a pain specialist that works with people with spinal cord injury or head injury, try to find somebody. You can call the number on the back of your insurance card, talk to your nurse case manager and say, we're looking for this kind of specialist who knows how to treat this with the condition that we have. And they will help you find somebody that's covered by your policy. It's the same thing for Medicare, Medicaid. So it works out really well. Okay, here's a very interesting question, because this is a subject that's near and dear to my heart. It says, given today's research outlook, how do you view the pros and cons of nerve transfer and tendon transfer surgeries for a C5 tetraplegic with no hand function? Are they still worth it? And I think you're talking about the ARC-EX, that nerve stimulator that I was talking about, external to your body. So you might want to go to Onward Medical and look up the ARC-EX nerve stimulator. It's the company that makes it's called Onward Medical. And look and see if there's an area, if it's in your area, so that you can get the stimulator, because it's in different clinics. They're putting it in different clinics right now. So see if you can get in that, or if you can get in a study. Now, if it's going to be quite a while before you can do it, you might want to opt for a surgical procedure and do the nerve grafts and the transfers. Those are viable options, both of them. So you're going to have to decide, do I want to wait? Because, it might be a year or two before it comes to your area, or it might be, it might come sooner. Or do I want to go ahead with a surgery because I want to have hand function now? So, this is one of those, well, nobody has the magical answer. This is something that, you're going to have to decide on your own. Let's see. Oh, stem cells. And I do like to talk about stem cells because in the 1990s, if you were around, this was the holy grail. This was the thing that was going to cure everybody. And I was in on this, and it was very, very promising. And the more research that was done, the more we discovered how complicated it was. Now, they have done a lot with people with heart trouble and, of course, cancer. They've done a lot with stem cells, but nothing is as complicated as the nervous system. So they are making a lot of progress, but stem cells have not made it to prime time yet. And, look at how long since the 1990s, and we're still trying to figure it out. The amount of work that they have done has been really great, but it's not really for prime time yet. There are some studies that go around. You will find a lot of people who will want you to pay for stem cell treatment. If you have to pay, then it's not legitimate stem cell treatment if you're paying out of your pocket. All the stem cell studies that are legitimate are still studies, so they're research, so you don't really pay for those. And you can go to clinicaltrials.gov and look up stem cell treatments for spinal cord injury or head injury or whatever neurological disease that you have. And you can see what studies are going along. What's nice about that is they'll have a little paragraph for the public. So, it's very scientifically oriented. And, if you don't have that kind of background, which, most people do not, but it has a paragraph for the public. And so you can follow along and see what's going on, get to know the names of the people who are doing this kind of research. So it's kind of helpful to follow along so you'll know when you're ready to take part in this. There's somebody who said that somebody is doing a stem cell trial that made somebody stand up. Could they be doing that? Yeah, it's possible, but again, it's not prime time. This is not ready for everybody to have. It will be a part of I think it will be a part of the bigger picture. I think in the end, when they figure out the whole constellation of how to fix the spinal cord or how to fix the brain, I think it'll be a part of that, but we're just not quite there yet. And it's very disappointing to people like me and, that, have been hearing about this for so long. Are there options for spinal cord individuals with scar tissue? Well, now this is kind of a tricky question for me because whenever you get a cut on your skin, you can see that you get a scab and then basically a scar forms. If it's a little tiny cut, the scar kind of dissolves over time and you don't see it anymore. But there's still a scar there on your skin. It's just underneath your skin, but it's still there. Bigger injuries, of course, have bigger scars and you can see those for a longer time. Well, the same thing happens if you have a heart attack. You get some scar tissue because there's been some damage to your heart. And in the nervous system, it's the same thing. So anybody who has injury to their nervous system is going to have some scar tissue because the nervous system's going to say, oh, there's an injury here. And what it's supposed to do is develop a scar to wall off the injury so the injury doesn't spread. That's the way your body heals yourself in your skin, in your heart, in your brain, in your spinal cord. That's what happens. So if you're worried about having scar tissue, yes, you have it. And the scar tissue is there for a reason. Now, it makes it difficult to get into the injury, like to deliver stem cells. But we have all these other treatments now. So I don't know if you're talking about scar tissue, like it's some kind of a problem in there that's, because sometimes there's a lot of scar tissue. Sometimes it's just this natural process. So having scar tissue, if somebody says you have scar tissue around your injury, that's a normal thing. So I hope that answers your question. Here's a man that has been injured. He has a standing wheelchair. How often should he stand? So if you have a standing wheelchair, I would assume your healthcare professional has checked you out so that he knows that you have the proper bone density, that you can stand. You don't want to stand and have your bones collapse under the weight of your body, or that you don't have blood clots in your legs that are going to be dislodged. So if you have a standing wheelchair, I'm sure your physician has checked out. Now, with the standing frame, we recommend that everybody stands for an hour a day. It doesn't mean you can do that the first day. You might have to build up to it, or you might have to, like go up and be like at a half stand for a week until you can get to a little bit higher and a little bit higher. But with the standing wheelchairs, usually you can go up and down. You want to reach something on the shelf, you can use that to go up. You're in a conversation with other people in a group of people, and you want to be, they're all standing and you want to stand, you can stand in that conversation. So it really depends on what your tolerance is to standing. But for standing as a therapeutic exercise in general, this may not be for you, but it's usually to stand for 1 hour a day, but you have to work up to it. You can't just go and stand and think everything's going to be okay. Now, there's some people that have written, oh, one more question about that. Can a commercial electronic abdominal exercise machine replace a TENS unit? They work on different amounts of current that are sent through your body. So some of the ones that people buy, and these abdominal exercisers, sometimes people with flaccid abdominal muscles will use those and they will work, but the TENS unit works differently, that has more power. So you would have to talk to your healthcare professional to see about that. The abdominal exercises you can just order, and I've seen them on TV, and it's this thing, and it kind of um, uh, exercises your abdominal muscles. So you would have to check with your healthcare provider to see if that is right. But generally, one works on a higher power than the other, and so usually people with paralysis need the higher power. So you will have to check to see with your doctor about that. They sometimes help if you have an abdominal exerciser. It sometimes helps with your bowel function, because it's giving some exercise to that muscle. And part of the way your bowel works is when we're up walking around and using our abdominal muscles, that helps anybody's bowel functions. Also, if you're using that, it's kind of disturbing the bladder. So it's kind of shaking your bladder up a little bit. And so that helps prevent some urinary tract infections. So we think it physiologically, it makes sense. I don't know if anybody has tested that out exactly. So that's kind of something to think about. Now, back to the standing wheelchair. There's some people that have written in, and there's a couple of people here. One person is getting, they have low blood pressure, both of these individuals. And so if you suddenly stand up and you haven't stood up for a long time, or you're not used to it, your blood pressure is going to drop. Because when you have paralysis from a head injury, stroke, from a spinal cord injury, or from neurological disease, if you haven't stood in a long time, your muscles, either in both of your legs, if you have a spinal cord injury or neurological disease, or if you have a head injury, you might just have the muscles in one leg not functioning very well on one side of your body. It doesn't work so well. So when you go to make that abrupt stand, sometimes your blood pressure drops. Now, some people's blood pressure just drops with neurological injury. Over time, it tends to come back for most people, and it'll creep back up. So you kind of need to always watch your blood pressure to see what's going on with that. So for the person who's been driving and they get dizzy while they drive, you need to go to your doctor, because you cannot be out driving and pass out. It will hurt yourself, and who knows who else you will be hurting. So when you have this, like both of these two people that wrote in, the one guy's had an injury for 23 years and he's starting to have low blood pressure. The other guy's having extremely low blood pressure and gets dizzy when I eat and when I talk, which is not really unusual, because that when you eat and talk, that involves a lot of the phrenic nerve. And so sometimes it's that phrenic nerve in there that's having some struggle. But if you're having both of these two I assume they're gentlemen, maybe not, but both of these two people need to call their doctor and get an appointment right away, because there is medication you can take for low blood pressure so you don't have these problems. The first line of treatment is to go back to those thigh length, toe to thigh elastic hose, which everybody hates, but they help constrict your blood vessels, which helps bring the blood back up to your heart and to your head, which is why you're getting dizzy. And so that's very important to have those. Some people will use an abdominal binder also because your muscles in your legs, your abdomen gets lax, and you want that blood to push back up to your head so you don't have these problems. But this is the problem where you call your doctor and say, I need to come in and discuss my blood pressure problem with you right away. So that is something very important to do. But that's the first line of defense is to put on the TED hose, the abdominal binder. Some people will wear TED hose and will take ACE wraps and wrap them on top of the TED hose to get their blood pressure up enough so that they can participate in sitting and or standing activities. You always, if you put a TED hose or ACE wraps around your legs, you always start from the toes and work up to the heart. If you go backwards, you're going to pull the blood down and rob your heart of even more blood. So that's an important thing to know. Muscle spasms that drain energy and impacts sleep. Yes, you need to take care of that problem because if you have muscle spasms, that's, it's your legs moving. It can be very good exercise actually, but it's painful and it disturbs people if they're in the wheelchair and their legs fly out of, it can be embarrassing for some people. It doesn't really hurt anything unless you have pain that goes along with it. And I know somebody else was talking about they're having their toes contract due to spasms. And so there are treatments for muscle spasms. The number one treatment, again, is movement. And I am really on a movement kick today. But most people, they become paralyzed. They sit down in their wheelchair. Well, my body doesn't work. And so they just ignore it. And, they move on with life in the wheelchair, which, yeah, it's important. This is the way it is. And it's important to move forward in life. However, with spasticity, it's your body is craving movement. We all have muscles that push and we have muscles that pull towards us. So when you have spasms, it's those muscles they're telling you, I want movement. One of the first things people unfortunately give up when they come home from the hospital is they stop doing their stretching exercises. Your muscles require this, your body requires this. So you have to get back in and doing these things, stretching those muscles out. Now, if the stretching no longer works and you need something more, there are medications that you take. They go through your whole body system, so that might make you feel tired. Some people take them and they find them quite satisfactory. Some people don't like medicating their whole body for a problem in their leg. So a lot of people now are getting Botox injections to help reduce their spasticity. It stays pretty much in the muscle where it's given. And so it doesn't spread through your whole body. It doesn't really affect your brain or your thought process. So those are things that people are doing. But whatever you're doing, if you have spasticity, if you don't have spasticity, your body is craving movement where you can't feel your body is still craving that movement. So it's really critical that everybody with any kind of paralysis does their movement. Let's see what else we have going on. Somebody is worried about their gastric paralysis, and that happens with neurogenic bowel. And so you have to perform the bowel program to take care of your bowel. If you have an injury in the higher part of your spinal cord injury or in a part of your brain, it's called an upper motor neuron injury. Your doctor has to diagnose this. If it's in the lower part of your spinal cord or in a different part of your brain, it's called lower neuron motor injury. There's different bowel programs for these two different injuries. If you have the upper motor, your body is more reflexive. It has more tone. It has more spasticity. So people with quadriplegia have more spasticity. People with paraplegia have flaccid, a flaccid lower body. They have no tone. And now if you have a neurogenic and some kind of neurological disease, it could be either way. It just depends on where your disease has affected your brain and spinal cord. And if you have a stroke, 60% of people with head injury and stroke have a neurogenic bowel and bladder too, as well. So it really is diagnosed by your doctor, but you want to do your bowel program. So, it's a suppository and dig stim for the upper motor. If you have no tone in your bowel, then you just wait until stool collects and you manually remove it. Now, if somebody had written in about their son who they want to get their son to transition. I don't know how old the son is, but they want to get their son to transition to doing an independent bowel program. They have some hand function. I can tell by the level of injury. They're at a T6-7 level of injury, so they should have some hand function. But as I often say, I've never met a patient. No one ever has ever said, when you explain the bowel program, "Oh, goody, I can hardly wait to do my bowel program. This sounds fabulous." People want to get in and they want to get out. So there are a couple of things to remember about the bowel program. And a lot of times people say, "It just doesn't work for me. I just don't get it. It just doesn't work." There's a couple of little things that are very important. First of all, when you put the suppository in, it has to go against the bowel wall. It won't melt unless it's against the bowel wall. So if you have stool in there and you push it straight up and it goes in the stool, it won't melt. So it's like you've not even put it in. The other thing is, when people do the dig stim, they want to go in and they do that dig stim like this as fast as they can because they want to get in and get out. Well, now think about when you have a spasm or something, it's the muscle contracting tighter. So the faster you do the dig stim, the more you're making the inner sphincter, the one you can't see, not the outer one that you can see, that's on the outside of your body. There's an inner sphincter about the length of your finger up in your bowel. And the faster you do that dig stim, the tighter you're making that inner sphincter. So the longer you're making your bowel program because it's clamped down in there now. So if you're like this gentleman that's not doing his own bowel program, and so a lot of times family members do it, my family member's been through so much, couldn't you just handle this for me? But there gets a point in time, you think about your children, and when they get to be about age 4, you don't do their toileting with them anymore. So if they have hand function or if they have the ability to do the bowel program, they should be doing that on their own. That's a personal, private thing that a person does. So for this mother that's doing her son's bowel program, there are a couple of things. First of all, I would recommend that you get a third party, a counselor, a therapist, to talk to your son about the bowel program. Why doesn't he want to do this? It might be that he's just like, "Ew, I don't want to do that." Or it might be that that bowel program is representing his paralysis and he doesn't want anything to do with it. It could be a lot more than as the mom, or it could be more deeper feelings than he knows or that he's even thought about. There could be a lot more emotion to it. So it'd be better to take yourself out as the third party, as the intermediary, and let the third party be the one that your son gets angry with, because the third party says it's time to now start doing your own bowel program. And you can tell the therapist, "This is why we want to transition, and we're having trouble transitioning to this." And you don't have to hide it from your son. You don't have to hide it from the therapist, but the therapist will be able to help with that transition. The other thing is, there are available on the internet an inserter for the suppository. It's a cuff that goes around your palm of your hand, so you don't have to have finger function, and you have to lubricate it just as you have to lubricate your finger, and you can insert the suppository. Remember to hook it over so it goes up against the side of the bowel so it will melt, and so they can insert the suppository on their own. Then there's also a separate device, and why these aren't all one device, I don't know. But there's a separate device that's a digital stimulator. And again, it just clips onto the hand. So if you have arm function, again, you have to lubricate it really well and very gently. You want to do your digital stim. So those are a couple of things, you might want to use those two devices. You can get them through insurance. You can buy them online yourself. It just depends, if you want to just outright purchase it or do you want to, go through your insurance. And so you can, whatever your decision is about that. But that's a good transition because after a while, they'll be using the digital stim and the suppository inserter. And then after they get used to doing that, after their while, I could just do this with my finger. It's quicker, easy. I want to get this done. And so it can be used like kind of as a transition. Now, a lot of people that don't have hand function, they just use these and they work out just fine. And so it's kind of a bridge if they don't want to put their finger in their bowel, it's kind of a good transition to do that. So that can really help a lot. Somebody says they're not walking as well as they used to, and their neurologist doesn't seem to do anything about it. Well, have a frank discussion with your neurologist. I've been telling you I'm concerned because my walking isn't as good. And I've mentioned it last time I was here, but we don't seem to have a plan for that. Could you tell me what your thought process is? If you have a neurological disease, maybe it's a progression of the disease. So maybe, he's thinking, well, you should kind of know this, but, maybe you haven't thought that way. So, there's all different kinds of reasons. So, and if you find that you're just not getting success, because you want that good rapport with your healthcare professional, if you think they're not listening to you, or you're not getting the services that you need, you talk to them and ask them why you can't have this or why this isn't going this way, or, what do you ask them what their thought process is. And if you're still having some trouble, you can always call that number on the back of your insurance card, talk to your case manager and say, I'd like to get a second opinion. Could you direct me to somebody who treats people like I do with this kind of issue? And they'll be able to direct you to someone else that maybe you might find more satisfactory with what's going on. Let's see. Somebody wants to know about cancer screenings. Are people able to find accessible resources, and what's some useful adaptations? Well, this is a problem where people with paralysis, especially those who cannot stand. So like if you go to have a mammogram and you can't stand to get in the mammogram machine. Now, some places have machines that come way down low to where you are seated, but most places do not, because maybe they don't have that population that demands that. And so that's a real problem. So you can also have an CT of the breast done. And so a lot of doctors will just order that for women instead. There's also things like if you have to go for a colonoscopy, a lot of insurance companies will now pay for you to go into the hospital the night before for the bowel cleanse instead of trying to do that at home where because the results are going to be unpredictable and, it kind of gets to be a mess to do at home. So a lot of insurance companies are covering for that now. So just talking to the healthcare provider and knowing what some of these different options are really helps, to be able to find out these things. And so there's different things that can be done, but it can be a challenge depending on where you go. If you go to like a large academic medical center, a teaching hospital, they're going to have a lot of this higher level equipment around, but not all of them do. Or maybe you might have to go to like a different department to get the kind of treatment that you need. So these are all issues. I'm going to answer some questions that people have written in. Helene writes, is there a preferred mattress or mattresses that you can recommend? No, it really goes by your body and what your needs are. So there's bariatric mattresses, there are water mattresses, there are rotating mattresses. It all depends on what your body dictates you need. So there's not like there's not one mattress out there that you can say, this is the end all be all mattress. This is the one that everybody should be on. It really depends on what your needs are. So if a person can turn themselves at night, they would get a different mattress than a person who is a high level tetraplegic and maybe they need a mattress that rotates their body. So, these are some issues. It all depends on the person. Have you had a pressure injury? Have you not had? There's so many variables out there. This new medication that's out there about for pain, for neuropathic pain, and so we'd have to look that up. It's a non-opioid. Does it help with nerve pain? If it's a non-opioid acting like an opioid, would it help neuropathic pain? The opioids do not help. Now, I know this says non-opioid, but there's different kinds of pain, and opioids are addictive, first of all, so you kind of want to avoid that anyway, but they don't treat neuropathic pain. So if it's a non-opioid, that means that the medicine works like an opioid, so it probably would not. Okay, the gabapentins make you sleepy and gain weight. Uh, um, they're addictive and leads to lethargy. Yes, the gabapentinoids are, a lot of the pain medications are addictive. You cannot just stop them. And I tell people all the time, if you're going to go off one and go on to another, or you're going to go off your any kind of neuropathic nerve medication, if you're going to go off one, you have to taper off them. And I have people that would come into the clinic all the time. I tell them, yes, 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 you're right, you're right, you're right. The next time I would see them, well, Linda, I didn't follow your advice and I went cold turkey, and it was horrible. And it is horrible to go cold turkey off these drugs. And the other part of it is when you go on another pain medication, if you've gone cold turkey, it's much harder for the new medication to work. So that's a real problem. So you want to taper off these. Now they are addictive. Well, now what does that mean? Does that mean you're going out on a trip someplace, you're having some kind of psychotic? No, no. But your body becomes dependent on these medications. That's why you can taper off of them. And if you taper off, you will be fine. And you can try others. Now, usually the tiredness that you get on the gabapentin, that usually goes away over time. A lot of these medications, until you build up your tolerance on them, or maybe you started on too high of a dose. As I said, everybody's pain treatment is different. Everybody's pain is different. So it's an educated guess on how much you should go on. I know from my own personal experience, not with the gabapentins, but with a lot of medications, I'm real sensitive to them because I've not taken a lot of medication in my life. So if you have trouble going on medication, some people will have difficulty in getting on the medication, and sometimes you need to back off. Over time, you'll need to go up on your medications. So this is all thoughts you have to take into consideration with any kind of medication for neuropathic pain. Toenail fungus, any home remedies, as the RX treatment gave me adverse effects? Well, there are a lot of treatments for fungus. There are treatments over the counter that you can get, and people find that those work, perfectly fine. There's a lot of medications that are prescribed. Some you take through your body, and that really gives you some adverse effects. Some is like a fingernail polish that you paint on your toenail, and that's kind of more like the kind you get over counter. And so I don't know which kind you had, but either one of those seemed to work. The kind that you paint on really seemed to work well. You have to go around on the toenail, and then you have to kind of put it underneath the back of your toenail so it kind of goes in there, and then around the whole toenail you have to go ahead and paint that. So, it's kind of like a messy uh, toenail painting job. Okay, I'm a C5-6 quad. Oh, and it takes some time. It doesn't happen overnight like they show on TV. It takes quite some time to get that taken care of. C5-6 quad, 30 years, and had a colostomy placed 5 years. It's changed their life. Should have done it. Are these more common? Well, a lot of people opt for the colostomy. Now, some people don't care for the colostomy, and it's a personal decision. It really is a personal decision. I like to warn people that, especially in the higher level, but any level of injury or any neurological problems, it's a surgery, and surgery have risk, and sometimes it's more difficult to get off the ventilator. People have died during their elective colostomy procedure. So it is not something to take lightly. Also, some people, because of the lax muscles in the abdomen, sometimes it's very challenging to keep the bag on. Or if you transfer in the way you move, the bag falls off. And so a lot of people have a lot of trouble keeping that bag on. If you look at the pictures, if you go look up colostomy, and you see the pictures of the people who have colostomies, you see them with a six-pack. That just irritates me to death because most people do not have a six-pack, especially if you have paralysis and you aren't able to exercise your muscles in that way to develop a six-pack. It can become quite cumbersome. However, people who have them and they find success with them because they wanted it and they have that, they're very, very happy with them. Some people are very happy. Some people say this was the mistake of my life. You really have got to talk to your healthcare professional and really talk this through. Now, the one thing about the colostomy is that you have, when it's an elective colostomy, you have the option of where it goes. So if you have it placed over the large intestine, closer to the rectum, you have a more solid stool. Some people prefer that. If you have it higher up in the large intestine, you'll have a more watery stool. Some people prefer that. So, there's all kinds of issues, but there are a lot of people who really admire the colostomy. But with that, I'm going to apologize again for the drops that we had. It looks like my sky is clearing. So I thank you for coming today, and I'll look forward to seeing you next month in October. And remember, some people are concerned about, they don't have the right system for getting these things. They're always available on the YouTube channel. So go to the Christopher and Dana Reeve Foundation on YouTube, and then ask Nurse Linda. And there's a lot, you'll find all of the webinars there, the professional webinars, the other webinars. And then if you have a question that you want to ask directly, because somebody said, I can't type in fast enough to ask my question, that's fine. But you can go to the foundation website, scroll down to the bottom of the page. There's a blue button there. It's pretty big, right in the center. And you can press that blue button. You can type in a message to me. It will come to me and I will answer your question to you directly. So that's a handy thing to do. So anytime you want to do that, that's perfectly fine. And again, oh, one more thing. There was somebody who wrote in about psychological references for children. And so there's some coloring books that we have, and there's some information we have. And then also I'll be talking to Dr. John, and we usually put in all our webinars a few words about pediatrics. So we'll be looking forward to seeing you on that webinar. So thank you for coming today.